I'm a research professor at the University of Washington School of Nursing, and one of the people had asked about training opportunities. I am the director of a small nonprofit that teaches clinicians in the approach I'm going to be talking about. So that is a resource if people want to look at this at the website to look at that. But also in there on the resources tab of this website are a number of podcasts. So one of the podcasts that might be most helpful for people to listen to as clinicians to think more about this work in relationship to substance use disorder specifically is it's probably the top podcast listed on the website. It's an interview with the woman who does, oh my gosh, what's the name of it? I just spaced. Liberated Body. It's the Liberated Body podcast, so you'll see that there. So this is a short presentation time, so I want to try and have enough time at the end for some questions and discussion. I'm going to talk a little bit about the particular somatic approach that we're using in substance use disorder treatment. It's called Mindful Awareness and Body-Oriented Therapy, or MABT. This is an approach that I developed. It grew out of my 20 years in clinical practice. And then when I decided to pursue a PhD, I created a manualized protocol to use in research. And so I've been funded by NIDA, the National Institute of Drug Abuse at NIH, and also now through the HEAL Initiative, through NCCIH, which is the National Center for Complementary and Integrative Medicine, Health, to work specifically studying this intervention with people who have substance use disorder. And the current study that we're doing is with people who have opioid use disorder specifically. So I do have a slide at the end, which kind of addresses what was just being discussed about is what can you do also to focus on body awareness in your own clinical work. And Chantal did mention some of the same things that you'll see on this slide. So I want to make sure we're all on the same page in terms of terminology. So Chantal was talking about this term interception or interceptive awareness, and I know most people aren't familiar with it. It really wasn't used in the clinical realm until very recently. So interception is the processing of sensory input in the body, and it serves a homeostatic function. It's mostly unconscious. Bud Craig, who's got this reference down below, was the anatomist who traced the sensory pathways from the body to the brain so that we know that this sensory information is really serving this regulatory function on many, many levels. When we're aware of it, which we can be in some of the ways that are really basic and are very obviously related to regulation, as things like we're feeling hungry, we're feeling cold, we're feeling tired, right? Like those are sensations that you can tune into on an internal level that are very homeostatically necessary for health. But also we've expanded, those of us who are really involved in the study of interceptive awareness, whether it's from a clinical perspective or a neurocognitive perspective, we've expanded sort of how we understand interceptive awareness to include all sorts of awareness of sensation in the body. So that can be also where you're tense, where you have a tense muscle, or where you have any kind of emotional relationship to what you feel inside. So as we talk a lot, right, about having jitters when you're nervous, or flutters in your stomach, or tightness in your chest, all of those things are you can interceptively or internally notice in the body. So this is the reference down here is more of a conceptual white paper that's really related to interceptive awareness and health in a really broad sense. So when we talk about helping people to really learn these skills, which Chantal was talking about in quite some detail, we're in my work and in most of the work she was discussing too, we're talking about noticing people gaining skills to be aware of internal sensations in the body. And this is a fundamental aspect of any kind of mindfulness approach. So if for those of you who've had any exposure at all to mindfulness approaches, one of the basic ways that's done is people learn how to attend to the sensation of the inhale and the exhale of the breath. And that's a very fundamental thing that gets introduced in mindfulness approaches. And that process of paying attention to the inhale and the exhale of the breath, doing that is engaging in interceptive awareness. But what's often not done in mindfulness-based approaches, and this is why I was smiling when Chantal was talking, is really teaching people how to bring their awareness in terms inside their body. So especially if you're in a group class, especially if you've got a trauma history or chronic pain and you protect yourself from noticing internal experience, you usually don't know what to do. You know, you sit in this group class and people are saying, now do X, Y, and Z, and we're going to meditate. But people don't know how to bring their attention internally. And so as Chantal mentioned, they stay up in their heads, or they think about the grocery list, or maybe do it a little bit, but they're popping out all the time. And that's normal for all of us. But it's all on a spectrum of how well one can bring attention internally, and then how well one can bring attention into the body and different places in the body. So individualized support is really, really very often needed in order to learn these skills. And that's what this approach is really designed to do. And it's very much involves this process of reducing dissociation from the body, as Chantal was talking about. And by doing that, we increase physical awareness, where we have tension, where we have pain, where we have stress, our emotional awareness, and the linkage between them. And that is, as Chantal was mentioning too, that's where sort of at a very beginning place of using these skills, where people often really have no idea. They don't know that those that tight feeling in their chest is related to feeling sad. Like, it's just not, some of those things that we might take for granted, it's really not accessible to a lot of folks who have substance use disorder, especially if they have trauma and chronic pain. So making that linkage is extremely helpful. It's helpful because once you're aware of it, then you can engage more in self-care, and it all relates to emotion regulation. And we all know that emotionally regulated you are, the less risk of relapse. So that's just some background on the role of interceptive awareness in substance use disorder, essentially. So this particular intervention, called mindful awareness and body-oriented therapy, involves psychoeducation, involves touch-based coaching, and it involves mindfulness skills. It's 8 weeks. It's delivered individually. The sessions last an hour, a quarter, an hour and a half. And we always give home-based practice for people to really try and build their skills, because the goal is that when they're done with the 8 weeks, they have a whole set of new tools in their toolbox, essentially, that they feel comfortable using in their daily lives. So there are 3 stages to this intervention over 8 weeks. And I don't have time to go into it in great detail. If you're interested in really reading about clinically both how this is designed, there are also vignettes to describe the stages, and it's framed within an emotion regulation conceptual framework. You can look at this paper that's been published that describes it. But basically, the concept is to teach people very incrementally these skills. They come in, and just like this man that was described in the case, they have very little access to their emotional material. And so we start with a process of helping people to really have language to do that. So it's just articulating and identifying sensory awareness. And we do that through touch. So but we stay more on the external, exterior of the body to start. So that the therapist is actually using touch and pausing in places where there likely is sensation because it's a tight muscle, for example, and asking the person to notice what the sensations are externally. But this process helps people really notice their whole body, but also really the point of it is to develop language. And then we move from there into doing exercises to help people bring attention internally. So that's more working with breath, softening of some of these tight places, but it's really more exercise-based to help somebody make this shift from external on the body to internal on the body. And then the last 4 sessions of this 8-week intervention are more mindfulness-based, where we've hopefully now helped this person learn how to bring attention to the internal space of the body, but now we're working on developing their capacity to maintain some of that attention in the body for a certain length of time. So what we've discovered is that, as we talked about, a lot of times folks start out like they can just touch in and then they pop back out. It's uncomfortable, it's unfamiliar. But as they learn to do this more, and you start in places that are more comfortable so they can maintain awareness, that by sustaining attention in very specific regions of the body, people become aware of, and they're guided in noticing what they notice internally. So it's very mindfulnessly focused, present moment attention to what they notice internally, that people's experience of their body shifts. They make connections emotionally, but also they tend to feel better. So you might start with a place that feels kind of closed down and dark and uncomfortable. And if you can maintain awareness in that space, it will shift. And that shift to it being a little lighter, a little more comfortable. And I could go on and on with examples, but that shift is sort of profound for someone. It's like, oh, it's okay to be in here. My body is actually I'm getting new information about myself. I'm making maybe some connections or having some insight into how I feel in this place. So it's got some of those same qualities that Chantal was talking about, where once someone learns some of these skills, they can use them as a resource for not only more about how they feel, but actually having a different relationship with their bodies, which is extraordinarily helpful for emotion regulation purposes. And it relates also to sort of the reappraisal that can happen on a somatic level of how one feels, how one relates to one's body, and the way that using the body as a resource for self-care, which is usually just completely not in someone's on someone's radar, how helpful that is. So in substance use disorder treatment, I will show you some of the results of from our studies that kind of clarify that. But first, I want to just mention some of this literature that really, I think, sets the stage for doing this work. We know that negative affect and stress are primary relapse risks post-treatment. That dysregulated emotion is linked to interceptive dysfunction in substance use disorder treatment. We know this from neuroimaging studies. Basically, this just means that people aren't processing interceptive information or sensory information in the body the way that healthy people who don't have substance use disorder can. This is not just true for substance use disorder. This is true for people who have all mental health disorders that have been looked at quite extensively in neuroimaging studies. And that high levels of interpersonal trauma are clear population, and extensive trauma is accompanied by disconnection from the body as a way to cope with emotional and physical pain. So by bringing these kind of skills to people is extraordinarily helpful. So I have a few slides here. You can really find all this information easily in PubMed if you just look up that. The articles, so all of this has been published, these next few slides, but this is a slide of, and there's a number of slides I'm going to show you that are from a large study with women in intensive outpatient treatment in a community setting. So these are all very, very low income people. They cannot afford, they don't have private insurance. Every single one of them was on Medicaid or Medicare, or every single one of them had a trauma history. I think 78% of them had screen positive for PTSD. And so they are getting, in this study, they're all women, they're intensive outpatient treatment, and they are assigned to either TAU, you can see in this little box, is treatment as usual, or treatment as usual plus this approach I've been discussing, mindful awareness and body-oriented therapy, or to control for time and attention and make sure that the changes we aren't seeing in mindful body awareness are not due to time and attention. They are getting an equivalent individual intervention that was women's health curriculum. So you can see one of the questions you always want to know is, are people learning the skills you're teaching them? And so we did that. We measured that with the MAIA, which is the multi-dimensional assessment of interceptive awareness. It's a scale that I helped to create, actually. And it's a long scale. These are just a few of the items that are really about, can I bring awareness into my body to notice how I'm feeling? Does it help serve me so that I feel more calm instead of overwhelmed? Those kinds of questions you can see on the right-hand side. And we can tell that people who got this intervention compared to people who did not significantly improved on this. And we followed them for a year. And so the group time times interaction, that's looking at how these three groups combined at a year, we still see significant changes on this outcome compared to everybody else. So here we have some slides that look at depression and difficulties in emotion regulation. The first graph up on the left, we're looking at the brief depression inventory the Beck depression inventory. And you can see the dotted line is those who got MABT. They have a significant reduction in depression compared to the other groups. There's a fourth line here. Those are people who were assigned to MABT but actually never went to any sessions. So they look just like the treatment as usual group. Similarly, down with the difficulties in emotion regulation scale, we have a significant reduction in difficulties with emotion regulation for those who got the MABT intervention, but not the other groups. So obviously our primary outcome was substance use. This was funded by NIDA. And you can see that from baseline, this to 3 months, that all of these people were doing pretty well on their percent days of abstinence for substance use while they were in treatment. Their intensive inpatient treatment went from baseline to 3 months, and then they were still in treatment until 6 months, just not intensively, which follows the typical outpatient trajectory. And what you can see is that those who had the women's health curriculum were equivalent to those who got mindful body awareness. So time and attention really, really matters, as we all know. And, it helps people do better. But once all of their treatment was really done, which was at the 9-month time point, then that dropped off. And only those who were in the MABT group had sustained lessened use of substance use. Now, these women, overall, their abstinence levels are pretty good. And these women were highly motivated to maintain their abstinence. Almost all of them, or a huge percentage of them, I can't remember it off the top of my head, had child protectives and services involved. They were at risk of losing their children. So we see that as well in this. The other thing we did is we looked at respiratory sinus arrhythmia, which is the same as heart rate variability, to look psychophysiologically at emotion regulation. And this is the first study that really was a clinical study that sort of supports the neurocognitive research that's been going on looking at interception, that we see this increase in emotion regulation psychophysiologically by those who got Mabt compared to the other groups. You can see the big jump during the intervention period, and then it's sustained out a year. So this really relates to this whole concept that interceptive awareness is very, very important for emotion regulation, and we're seeing that in these results, which is pretty exciting. So, as I said, right now I'm funded to look at this intervention for people who are on medicated assisted treatment for opioid use disorder, and this study we're early on in this study. It's going to be it is a 2-group randomized control trial. The sample size will be 330 if we're lucky. Size trial. Assigned to usual care or usual care plus Mabt. It's delivered in community primary care clinics, use disorder treatment. And we're only right now, hopefully we'll be able to maintain this, working within programs that are using a nurse care manager model program. So we have 2 urban clinics and 1 rural one. Participants, again, they're in the program for a year. We do 5 assessments to look at their change on measures over time. To date, there are 94 people in the study, 50% of chronic pain. And this is the first study using this intervention where, well, I've done some little studies, but this is the only big study where we've had men included. So there was always that question, by clinicians particularly, are women going to be is this going to be a more acceptable intervention to women than men, or something that they seek out more than men? And I can tell you, at this point, we've been doing this study for a little over a year, that is absolutely not the case. So the men love this work as much as the women, and there's no trouble enrolling them. So I just thought I'd put this slide up for fun. I don't have any data from this study to share, but those, in terms of our measures and outcomes, but we ask all the people who finish the mindful body awareness intervention to complete a little survey specific to their experience receiving this approach. One of the questions is, did the Mabt program help or hurt your treatment or your ability to meet your substance use goals? And you can see for this small group of 15 that 11 out of 15 said it helped a lot. And 3 that it helped a little, and 1 that it didn't hurt or help. And then the follow-up question is around, well, how did it? Give us some examples of the ways in which it had an impact on your substance use from your perspective. And so just looking at what they wrote, because this is where they actually write out sort of a written questionnaire, their responses, 3 themes emerged. 1 is increased capacity to manage distress, including substance use, sort of opioid cravings, pain, and negative affect. So the numbers there are the number of people who said this in response to that question. Another theme was just overall feeling better. So having a more positive attitude, more commitment to recovery, which is really key because in opioid use disorder, a lot of people get on buprenorphine and they feel they kind of get their lives together a certain way. And then I think clinically, one of the things that sometimes happens is then they're like, well, okay, it's 6-9 months later, and their commitment to their treatment may wane. And we're seeing this. We're seeing people saying, I'm so glad there's something more I can do because I need a little more help right now. I'm, for whatever reason, whether it's economic or emotional stress or people are hanging out with, whatever reason, they feel more at risk for relapse. And so this is a really big concern that how do we help people stay on buprenorphine? So it's interesting to hear them say this. And overall well-being, as well as the other thing being more self-awareness. So anyway, it's been fun to do this study in a very different setting in primary care clinics and with nurses compared to in the community. But I do have to say that this, what Chantal was talking about, if there's a resource that you have in your community to send people who have insurance, private insurance, to get this kind of care, it's wonderful. But so many people, that's not an option. And it's a huge barrier to being able to provide the kind of care we want to and access to care for people who are low income. And we haven't figured this out yet in our country. I'm hoping this kind of research will help move some things on a policy level at some point. But in the meantime, for those of you who are clinicians and you're seeing people in whatever clinical way that you do, these are just some really small suggestions for ways that you can help your clients focus on tuning in to these kinds of things that Chantal and I are talking about. So one of them is just on their present moment experience while they're in the office with you. What emotions and sensations or body awareness can they tune into? Like just in the context of your clinical interaction, when you're asking them questions, if there are things that they come up, just asking them to take a minute and notice what they notice inside. Nobody usually asks people these questions, right? And it's enormously helpful because they'll often, they may say, oh, I don't know anything, but they may actually tell you they do notice something. And taking the moment to do that really models how important this can be. And it can actually maybe give you something new, a new direction to go with them, or that they can go on their own with. You can use a body scan for those of you who know anything about how to do that. If you do have that skill to promote awareness of internal body sensation. You can ask a client how their body feels when they express emotional distress. So it's that really basic linkage, which is extraordinarily fundamental, but extraordinarily important to help them notice if they're feeling pain or they're feeling physical discomfort, how do they feel emotionally in that part of their body when they focus on that part of their body, and just ask. And it will be interesting to find out what you learn. But for them as well, it helps them make that connection. Similarly, if they talk about how anxious they are, ask them where they notice that in their bodies. So we're focusing on simple things, but simple things are extraordinarily important. So another thing is, if someone walks into your office and they're just feeling really jittery or anxious, or talk about an increase in depression symptoms or PTSD symptoms or whatever, is to have them ask them, well, let's just put your feet on the floor for a minute. Just feel that sense of groundedness, or feel your butt on the chair, to help them calm down. But it also gives them, maybe nobody's mentioned these very simple things that they can do at home on their own. And then you can suggest that. You can do this home on your own. And then find out the resources in your community. Who has free classes or low income, sliding scale kind of services to help people learn these skills? Are there therapists that work, for example, that Chantal knows in some of these environments, who might see someone on a sliding scale? There's so many ways that these kinds of, we're so siloed, and people don't know who's in their communities. And so trying to get more of that information available to substance use disorder clinicians, that they can provide these resources in the community to their clients, is enormously helpful. And it takes a little work, but it's great if we can all help each other out in that way. So that's my presentation, and I'm happy to take any questions if anyone has any. I guess I have to stop sharing in order to maybe see questions. I don't know. I don't see the chat. So
if you look in the bottom right-hand window, you might see, well, I don't, everybody's screen looks different. I see a place that says chat in my bottom right.
yeah, no, I do now. I just had to stop sharing.
Okay. Okay.
Yeah. So let's see. I'm not sure where I should go back to. That's fine. Okay.
I don't know if there were any questions throughout the presentation.
Does anybody have any questions?
Yeah, I don't think you're not behind.
No questions?
We're overwhelmed with your intelligence. No, I'm just kidding. I appreciate your acknowledgement of the barriers to these services that exist for underserved populations and like lack of research in that population, because I think a lot of us work with that population. And I always say my patients fit all the exclusion criteria for all the studies out there, so they don't get included in the research often. At least much. Thank you.
Yeah, I mean, that's one thing we've been really careful about, is to have almost no exclusion criteria for our research, for that reason. So let's see, someone wrote, are there any negative side effects to this work? And thank you, somebody, for adding the Liberated Body podcast. Any negative side effects? We have had none. I mean, I've been doing this kind of work for, whether it's been clinical or research, for 40 years. And I've had two very, NIDA funded studies, and now this study with opioid use disorder that's been going on for the last year. And we've had no adverse events that are related to this intervention whatsoever. None. It's always a concern that comes up, especially with psychologists. I know most of you probably are not, but, it's like, well, touch, you're using touch, doesn't that, create the potential for more traumatization? And like, what Chantal was talking about with somatic experiencing, or the other kinds of internal body focuses that you can just integrate into whatever kind of approach you use, as well as with this approach, Mabt, the focus is so strong on having a safe interaction between the client and the therapist. That comes before anything and everything else. People are concerned, oh, well, you're doing a clinical protocol, are you standardizing it? We have a clinical protocol, but it is, the most important thing is that you do things that are at a pace and at a comfort level that match what your client can, that works for them, really. So things are not done exactly the same for everybody, because people learn in different ways. They have different levels of comfort with touch, with paying attention internally. They have different levels of potential dissociative responses to paying attention. It's all over the map. And so that is the most important thing. And when Chantal uses this language, which is psychological language, around the container, the safety of the container, or the therapeutic window, it's all about safety. So we do that above and beyond. I mean, that's first and foremost. And then everything else comes after that. And then when you know that that's your goal, is to make sure that you are not only making sure your participant is feeling safe, or your client is feeling safe, but that you're a partner with them in this work. And that it's not a power over kind of experience. You're together, exploring together and learning together about how they can use some of these, learn some of these skills and learn them for their own self-care. And it's a different kind of thing than I think people really, if you've never experienced it, might have different assumptions about it than are really the case. And so I think these are the reasons why we don't see adverse events. And there's another reason, which is, somatic experiencing can be done without touch. Chantel's got a therapist who's a body worker who's learned somatic experiencing. That's very common. My work, I started when I was 20 years old. I left college and took a break and became a massage therapist, right? Thinking I was just taking a break from college, not that this was going to be the rest of my career. But the work of using touch is very grounding and very centering for people. And so this idea that it can be re-traumatizing, well, of course it can be if there's not a safe environment and careful use of touch. But when there is, it is enormously helpful for people because it helps them pay attention internally. So because people tend to dissociate or to avoid paying attention internally, having touch helps them do that better. It's like, oh, my hand's here. I'm supposed to bring my attention here. And so even all of us, regardless of whether we have any of these kinds of histories, anybody will have a better and easier time paying attention to a certain part of the body if you put your hand on it, because it's concrete. It's like, oh, that's where I'm supposed to bring my attention. And if your attention floats off, you just bring your attention back to your hand. So it's like, where do I go when I start floating? Oh, I come back here. So there's all sorts of ways in which touch is extraordinarily helpful, especially learning this work. And then they can go home and they have their own hands and they can use their own hands to do the same thing. So these are really, really, really simple, concrete, fundamental skills. And that's what this intervention that I developed and teach and now study is all about. And, it can become a more extended kind of therapeutic work, but these fundamental skills are enormously important. So I just went on and on. Does the cost include all 4 classes or is each class separately? If someone wants to talk to me about Mabt training, you should probably email me directly. We can talk about that because that question needs a little unpacking. But you're welcome to email me, cynthiap@uw.edu, or there's a different email you can find on the contact page of the web of the Center for Mindful Body Awareness. Anything else?
Thank you so much, Cynthia. And again, Chantel, both really excellent presentations and information that I think is new and expansive to many of us. So thank you. Thanks for sharing your email too. You may get questions. And thank you, everybody. We'll see you next month. Happy Thanksgiving in whatever form your Thanksgiving holiday looks like this year. Have a good weekend.
Thanks for having us.
Thanks. Thank you all.